Hello, my name is Mark Pegram, Professor of Medical Oncology in the Division of Medical Oncology at Stanford University in Palo Alto, California, and I'm pleased to present this 2021 ASCO Direct Highlights update on the treatment of early-stage breast cancer. First, I'd like to begin with the Olympia clinical trial, which was selected for presentation this year in the plenary session at ASCO. Olympia is a phase 3 multicenter randomized placebo-controlled trial of adjuvant olaparib after neo or adjuvant chemotherapy in patients with germline BRCA1 or 2 mutations and high-risk HER2-negative early breast cancer. The premise behind the study is the fact that PARP inhibition causes cell death through synthetic lethality in tumors with homologous recombination deficiency that cannot repair double-stranded DNA breaks. Olympia was a large trial of 1,836 patients, and following randomization, the groups were well balanced for age, type of surgery, menopausal status, neo versus adjuvant therapy, type of chemotherapy, and hormone receptor status. The primary endpoint was invasive disease-free survival in the intent-to-treat population. This endpoint was met with statistical confidence with a stratified hazard ratio of 0.58, p-value less than 0.0001, and a 3-year absolute difference in IDFS of 8.8%, indicating a large treatment effect. Distant disease-free survival is also highly significantly impacted with a stratified hazard ratio of 0.57. Moreover, the overall survival hazard ratio was 0.68 with a p-value of 0.024, although this was not considered statistically significant due to the fact that this is an interim analysis with a target threshold for significance of p less than 0.01 in the alpha spending plan per protocol. Longer follow-up was needed for more mature survival analysis of Olympia. There were no new safety signals for olaparib in this study, with the most common adverse events being nausea, vomiting, anorexia, fatigue, and cytopenias, particularly anemia. The key take-home points for Olympia: addition of olaparib to standard therapy improved 3-year IDFS and distant disease-free survival for germline BRCA1 or 2 mutation carriers with HER2-negative breast cancer, including triple-negative breast cancers greater than 2 centimeters or lymph node positive, and hormone receptor HER2-negative patients with 4 or more positive lymph nodes, or non-PCR status after neoadjuvant chemotherapy, and higher tumor burden required for those patients that were hormone receptor positive and HER2-negative in this group. Results are considered to be practice-changing. Indeed, regulatory approval is being sought based upon the strength of the data in the Olympia trial. Second, I'd like to present an update on exciting breaking news from the immune checkpoint inhibition front for early-stage triple-negative breast cancer. At this ASCO, the GEPAR-NUEVO trial was presented. This was a randomized study of 174 patients treated with neoadjuvant nab-paclitaxel followed by FEC chemotherapy with or without durvalumab. Previously published results indicated only a small non-significant change in PCR rates with neoadjuvant durvalumab in this study, but at this ASCO, for the first time, the time-to-event outcomes were reported. With a median follow-up duration of 43.7 months, IDFS stratified hazard ratio was 0.48 with a p-value of 0.0398, which was significant. There were also impressive and significant improvements in both distant disease-free survival as well as overall survival. So the key question posed during this ASCO was, would these impressive time-to-event outcomes in GEPAR-NUEVO foreshadow the anxiously awaited time-to-event outcomes in the KEYNOTE-522 pembrolizumab study? And the answer to that question was just provided in a plenary session at this year's ESMO meeting. KEYNOTE-522 was a phase 3 study of neoadjuvant pembrolizumab with chemotherapy versus placebo with chemotherapy, followed by adjuvant pembrolizumab versus placebo for early-stage triple-negative breast cancer. The results demonstrated a statistically significant and clinically meaningful improvement in event-free survival favoring the experimental pembrolizumab-containing arm with an EFS hazard ratio of 0.63, p-value 0.00031. A trend towards improved overall survival outcomes was also seen with a hazard ratio of 0.72, although technically the p-value of 0.03214 did not reach the pre-specified boundary of 0.00086. Longer follow-up and more events are needed to critically evaluate the OS endpoint in this study. No new safety signals were apparent for pembrolizumab, with an adverse event profile largely demonstrating previously reported autoimmune phenomenon, this occurring most frequently during the chemotherapy plus pembrolizumab treatment course of this study. Based on the strength of the KEYNOTE-522 study data, On July 26, 2021, the Food and Drug Administration approved pembrolizumab for high-risk, early-stage triple-negative breast cancer in combination with chemotherapy as neoadjuvant treatment, and then continued as single agent as adjuvant treatment postoperatively. So the key takeaways at this ASCO, a breast cancer presentation in the plenary session puts ASCO 2021 into the win column. Adjuvant PARP inhibition in high-risk germline BRCA-mutant early breast cancer is practice-changing, and the time to event analysis of GEPAR Nuevo and Keynote 522 holds great promise for immune checkpoint inhibition efficacy in early triple-negative breast cancer. Overall, an exciting ASCO this year for breast cancer with 2 new treatment paradigms, including PARP inhibition in germline BRCA-mutant carriers with early-stage breast cancer and immune checkpoint inhibition in high-risk early stage triple-negative breast cancer. Thank you for your time and attention. Look forward to seeing you at the next ASCO-sponsored event. Thank you.